Okay, good afternoon, class. So this is one of the important topic for your clinical practice, epidemiology, as well as for your academics and examination. Okay. So today we'll have some discussion and basically application of validity, sensitivity, and specificity in day-to-day clinical practice, especially in the context of COVID-19. We'll try our best to apply the concept of validity in our upcoming days. Okay, the basic terminology already discussed in your previous class. So today I'll try to summarize the important points and its applicability. Okay, and this is very, very important for an examination point of view also. Okay, so please try to be very careful. And if you have any question queries, so we'll have discussion within this class time or off time. So it's within a group or individual mentorship. So you can discuss anytime regarding this topic or any other related to community medicine in other medical subjects. Okay. Let me continue. So at the end of this interactive lecture, its students or participants will be able to understand the meaning of validity and its application in the real context. And within 1 hour, we have 40-minute class, 15-minute evaluation, and 5-minute feedback. So I'll evaluate all the students through reflection writing, MCQ test, and others. So this is portfolio assessment. Okay, I'm not, very much sure about exams, traditional exam, but portfolio assessment is quite good. So your attendance, your participation, your timely submission of reflection writing, MCQs, and your interactive, nature. So this helps you to secure at least a good mark in your community medicine subject, because this is nature of subject too. Okay, now what is validity of a screening test? So we already discussed there are different types of test strategies. Okay, one group of tests for screening purpose. Our objective is basically screening, basically for outbreak condition or population health. And another group of tests is for diagnostic test, for diagnosis, for hospital-based diagnosis, or for clinical services. We start our especially clinical treatment or hospital admission. So while applying any test, either a screening test or a diagnostic test, we have some quality controls. We have certain parameters of the test. For that, we need to know what is validity and what is reliability. Okay, so validity and reliability. And reliability is also called repeatability. But the main focus today is validity. Okay, so validity of a screening test is defined as ability of test to distinguish between who has the disease and who does not. And I already told you validity or sensitivity and specificity or accuracy all are same. There are different terminology, but they are same. And the validity or accuracy has two components. One is sensitivity, another one is specificity. Please be very, very careful in this terminology. This is very important. Sensitivity. What is the definition of sensitivity? It's the ability of test, screening test, or like RDT kit for COVID-19 to identify correctly those who have disease or true positive. This is called sensitivity. And specificity is defined as the ability of the test to identify correctly those who do not have disease or true negative. Okay, those who have disease and which is exactly identified by this applied screening test or RDT kit for COVID-19. This is called sensitivity or true positive. And ability of test to identify correctly those who do not have disease or true negative. So there are two terms. One is true positive, that is sensitivity. True negative means specificity. Please recall once, okay? Sensitivity and specificity. True positive, sensitivity. True negative, specificity. Now, let me try my best to use terminology or components: sensitivity, specificity, true positive, true negative, or false positive and false negative through this 2x2 table. Okay, so actually we use a 2x2 table for analysis of sensitivity, specificity, even positive predictive value PPV or NPV of any test. Okay, you can see it's a 2x2 table. You can see 2x2 table. Screening test result. This is RDT for COVID-19 site, and this is for screening purpose, RDT for COVID-19, and this is COVID-19 RT-PCR, reverse transcriptase polymerase chain reaction. Let's consider this is one of the gold standard test. And through this RT-PCR, this number of people diagnosed is having COVID-19. Okay, so this is present. A plus C means through this diagnostic test or through this gold standard test is positive. And this second column is disease absent through this RT-PCR. So B plus D is total. B plus D total means disease absent. A plus C total means disease present through this test. If you go through horizontal, if you go to vertical, a row, A plus B means test positive through this screening test RDT, test positive. C plus D is test negative through this RDT kit. Actually, it has 4 components. Through gold standard or diagnostic, this is positive, A plus C, total positive, this is total negative. This is one set. Another set is through RDT kit for COVID-19, A plus B is test positive, and C plus D is test negative. So through our diagnostic test or RT-PCR, if it says positive and which is rightly detected by RDT kit, then it's called true positive or A. Okay, this is true positive. So if you divide true positive by total positive, A by A plus C into 100, then it is called sensitivity. So among the disease negative, RDT can detect this group of people as test negative. This is called true negative. So it's negative in both. Okay, it's masked. Disease absent, negative means absent. Disease absent, absent. Negative means absent and absent. True negative. So present and positive, true positive. And here you can see this is actually absent, but this test identifies it is positive. So it's called, it's a positive in this test, but it is false. So it is called false positive or FP. Second scenario, actually disease is present, but test is negative. So negative, it is false negative. It is negative, but it is false. Actually, it's a true positive. So this is scenario 2x2 table. And it's widely applicable in your clinical practice. Widely applicable. So clinicians are fond of using this table in their research, in their clinical work, in their epidemiological work. Especially in clinical epidemiology, we use this concept, even in lab medicine or any diagnostics. Hope it's clear till now. Okay, now let's try to define again. It's the ability of test to identify correctly all those who have disease, which is called true positive. True positive by true positive, false negative into 100, or A by A plus C into 100. Test has 90% sensitivity, means 90% of diseased people screened by the test will give true positive result, and the remaining 10% of false negative results. Actually, the concept of sensitivity, specificity, positive predictive value, and negative predictive value, PPV and PPV, you need to recall again and again. You try to go through different sensitivity and specificity kit, okay, RDT kit, and try to analyze. Okay, so you can go through some research article too regarding sensitivity and specificity. I'll try my best to share for your further readings. Specificity, ability of the test to identify correctly those who do not have the disease. That is true negative. And 90% specificity means 90% of non-diseased person will give true negative result, and 10% of non-diseased people screened by the test will be wrongly classified as disease when they are not. That is false positive. We have only 38 students, okay, and the remaining are absent. I don't know why. And you all know this is portfolio assessment. I don't know. I'm not 100% satisfied with blocks and that, but we have certain portfolio assessment or 360 degree evaluation. So while evaluating even in your in-block, so I'll consider this too, because only 39 students now is not enough. Okay, though there are many difficulties, circumstances. I know these things, but I didn't know regarding almost 50% student absentees in this class. This is not good. Okay, you need to be very careful. Though there are many problems, I know these things, but you need to be responsible yourself. It's quite difficult. Okay. So applying the concept of sensitivity and specificity to the screening test. So assume population of 1,000 people of assume 1,000 MBBS student of Virat Medical College. Okay. Let me give example of our own. Assume we have 1,000 medical students. So till 10 batch we may have 1,000 students. So 1,000 medical students and 100 have eye problem due to online class. Maybe 100 have will have eye problem or have eye problem now due to online classes since last 2 or 3 months, and 900 do not have the disease, any eye problem. And a screening test is used to identify the 100 people with the disease. Okay, let me see COVID-19. It's easy for you to understand. Assume we have 100 medical students and 100 contracted COVID-19 and 900 do not have disease. This result came from RT-PCR test. Okay. And if you try to use RDT kit in the same population, then we have this result. Okay, this is true characteristic of population. Actually, these are all hypothetical. It's not possible. Okay, these are hypothetical. Sometimes only in the lab or in the research part it's more applicable, but in the real scenario it's quite difficult. Okay, and for kind information, the government in Nepal using both RDT kit and PCR. So through their data, actually we can find the sensitivity. Now we have enough data. We can easily calculate sensitivity and specificity of RDT kit in context of our country. So we have PCR data, we have RDT data. So we can construct 2x2 table, and we can easily identify sensitivity, specificity, positive predictive value, and negative predictive value. So if any student interested, we can work together too. Okay. So you can see this is true characteristic of population. We have 100 diseased and 900 no disease. But our RDT kit can detect 80 out of 100. This means 80 means true positive. So this is positive group, and positive by screen test means this is true positive. Actually, this is positive but negative by this test. So it is false negative. Okay. And similarly, among no disease, it's truly identify 800 is negative. So which is true negative. Okay. So 800 divided by 900. So this is for sensitivity and specificity. So here is the calculation. It's easy. A by A plus C, 80. True positive by true positive plus false negative. So 80% sensitivity means the RDT kit developed by some pharmaceutical company or manufacturer has ability to identify or screen 80% of COVID-19 cases. So it can easily miss 20 COVID positive cases because 100% sensitivity and specificity is very, very difficult. So if you try to catch more COVID-19 cases, especially in outbreak situation, pandemic situation, you need to increase the sensitivity. So 80% sensitivity is not enough. You need to increase its sensitivity, maybe 99%. Still, we can miss one case. So our diagnostic test or screening test, which we are currently using, would not reflect the real scenario of COVID-19 in our community. Okay? That we may have to follow other diagnostic modalities, not only the lab-based, but epidemiology-based or clinical-based or any history like epidemiology-based. We have to use multiple type of the modalities, and this is very important. Okay, and you can see specificity is 89%. Is more specific, okay, than sensitive. Let me go to next. So this is one example from diabetes and non-diabetics. So it's adapted from Bloomberg School of Public Health. So I already acknowledged this in my last slide too. So you can modify here diabetics in terms of diabetics, COVID-19 and non-COVID. Okay, COVID positive, COVID negative. So there is no demarcation between COVID positive and COVID-19. COVID positive and COVID negative. There is no. Okay, and even within COVID positive, there, so actually what we are using, PCR, RT, these are qualitative basis. It's not quantitative. Okay, if you quantify the amount of antibody or antigen level may be different within COVID-19 positive cases. That is called viral load. Viral load may be different in terms of COVID-19. In terms of diabetes, blood sugar level. Okay, so we have 20 diabetics, 20 non-diabetics. According to this figure, if we use low cutoff point, low blood sugar level, then those who belongs to above this cutoff point, we can consider them as having high blood sugar level. So from this figure, you can see 85% sensitivity and 30% specificity. So how it will change? See, we have 85% sensitivity and 30% specificity. If it is lower, what is our goal? Our goal is we try our best to include all possible cases of diabetics from community, but it severely decreases our specificity. We are not specific, so we are more sensitive because our goal is try to pick more diabetic cases. Hope you understood till now. If you increase the cutoff, then our goal is we are more specific to diagnose or pick diabetic cases. So what will happen? Now it will decrease sensitivity to 25 and increase specificity to 90%. It's more specific. So if you increase cutoff point, what will happen? Specificity increases, sensitivity decreases. If you lower the cutoff point, sensitivity increases and specificity decreases. It's a common question in your MCQ. Okay, please read it again and again. Actually, in the population, the diabetics and non-diabetics both are mixed, or COVID-19 or non-COVID both are mixed. Actually, there is no color demarcation. In fact, there is no color or label. So he is diabetic or she is diabetic, this is non-diabetic, or he's suffering from COVID-19. Actually, for COVID-19, due to some emergency, we have certain tag, but for other disease like diabetics, non-diabetics, even within community, those who tested PCR, they are tagged as COVID-19, but we have lots of asymptomatic cases and they are not tagged COVID-19 positive or negative. So actually it's mixed with, or it's within population, it's mixed within the population. So actually you cannot identify through any demarcation between diabetics, non-diabetics, or COVID positive or COVID-19. It's mixed population. So this is considered sensitivity and specificity. And if you use, now this is more generalization. Okay, in this figure you can see, if you use more cutoff point, what will happen? A screening test using a high cutoff point will treat bottom box as normal. If you put this as a cutoff point, high cutoff point, then you will treat all these population or persons, you will treat as normal. Though we have many diabetics. So we have only 1, 2, 3, 4, 5, 6, 7. So we missed more diabetic cases. Couldn't know how many from this figure. But we treat 7% as diabetics. In 2 or 3 maybe without having any diabetics. So we included non-diabetics too because of less sensitivity of our test. If you lower what a low cutoff point will result, identifying 31 subject is having diabetics. So if you increase cutoff point, okay, you can find only 7 cases of diabetes. If you decrease cutoff point, you can find 31 cases of diabetes. Almost more than 4 times, almost 5 times, more than 4 times you can see. So it impacts the calculation of the budget. It impacts human resource, everything. If we have 31 cases, which is almost 5 times, then sometimes we need to increase human resource or finance at least twice or thrice. So in the population health, it really counts. So as a future in charge of health centers or lead team leader, you need to be very careful while interpreting concept of sensitivity and specificity. While speaking with population or public or media or policymaker, you need to be very careful. Actually, this is good concept. Okay, as a doctor, you need to develop the concept of sensitivity or specificity. Actually, there is one terminology, clinical epidemiology. Every clinician should know the basic understanding of epidemiology, and this is important. Okay, to deal with your patient, or to deal with media or policymaker or with your colleagues with scientific evidence. Lesson learned: different cutoff points, different sensitivities and specificities. The cutoff point determines how many subjects will be considered as having the disease. The cutoff that identifies more true negative will also identify more false negative. Okay, true negative will also identify more false negative. Please, these statements are like your MCQs question. Try to visualize, try to recall once again and again through our previous slides of this class. Okay. The cutoff points that identifies more true positive will also identify more false positive. So let me go to next slide. Okay. So if the diagnostic test or confirmatory test is expensive, if a diagnostic or confirmatory, this is all generalization, okay, generalization of this concept of validity. If the diagnostic or confirmatory test is expensive or invasive, you need to break, or you need some intervention, invasive intervention. You need to minimize false positive or use a cutoff point with high specificity. If the penalty for missing a case is high, example, disease is fatal and treatment exists, disease easily spreads. If you miss case of COVID-19, then you need to maximize true positive because disease is fatal. Okay, in the context of COVID-19, disease is fatal or easily spread. So you need to maximize the true positive. That means you need to increase sensitivity. You need to increase the, you need to use RDT kit having high sensitivity. Okay, this is inference. So clinical significance. Hope you are getting my point. Okay, that is user cutoff point with high sensitivity. Okay, at least try to reflect one point from this class. If you have any disease with high fatality or high chance of communicability or spread and having proven treatment or having some penalty of missing case, ethical issues or legal issues, as a doctor, as a program in charge, you need to be very careful that your strategy must be identification or inclusion of true positive as much as possible. So 90% sensitivity test means still you can miss one case of COVID-19 because this is our limitation. We can't do anything. So we need to delimit. Okay, limitation and delimitation is different. Delimit means you need to limit yourself before the process. So I delimit myself so that the test kit I am using for this COVID-19, okay, is not capable to have 100% diagnosis. So government send us RDT kit to test our population, and it has clearly instructed that it has 80% sensitivity. Means you need to tell media or concerned persons it can still miss 20%. This is reality. But we need to be very cautious while communicating these facts because these are quite used in your outbreak investigation. During outbreak investigation, we need to choose speaker. Only one person is responsible. Like in our country, Nepal, we have speaker for COVID-19, Dr. Jageswar Gautam, Professor Jageswar Gautam, Wando channel. So we need to be very cautious while managing media or media control or media, to prevent media rumor. So we must have speaker. Now, these are the sensitivity and specificity of important tests. Mammography. Okay, even in our hospital, we have mammogram. I hope everyone know what is mammography. What is mammography? So, the sensitivity of mammography varies from 75% to 95%. And its specificity varies from 83 to 98%. So mammography from this sensitivity and specificity analysis, you can say mammography is more specific. It can more easily identify true negative. So it's a diagnostic test. Pap test sensitivity from 29 to 56%. I hope you know the full form of Pap Nicolau test, Pap test to diagnose cervical cancer in female. So we have different limitations of Pap tests. Before sample collection, we need to follow different advice from diagnostics or from doctors or healthcare providers. So it can have wide range of sensitivity from 29 to 56%. Specificity 100%, 95 to 100%. It's more specific, more diagnostic. Pap test, PSA test, prostate specific antigen. We have 20 to 32% sensitivity and specificity 94 to 97%. Please, after this class, please try to recall again and again and try to visualize yourself. Okay, you need to read at least 20 times. Otherwise, it's not possible to visualize this concept of sensitivity and specificity. It's quite it's not difficult, but you need time to understand. FBS, fasting blood sugar, sensitivity and specificity. Rapid ELISA, same. For PCR test for COVID-19, we have how much sensitivity and how much specificity. So for pregnancy test, for malaria RDT kit, for dengue now onwards, while visiting any pharmaceutical or sorry, any pharmacy, or while visiting hospital, and try to read sensitivity and specificity given in that particular test kit, okay? Or you can go to lab and you can easily find it. So this may be your task, okay, to understand more about sensitivity and specificity. Or you can Google it and you can find everything in Google Class. Okay. This is concept of sensitivity and specificity. So for a level, I think sensitivity and specificity, at least must know area. Okay, for your level, you should know what is sensitivity, what is specificity, and what is its clinical significance. So being a future clinician, you try to have some clinical significance, which makes it more interesting and which is more receptive for you. Okay, I know these things. Okay, and another one is positive predictive value and negative predictive value. Though we have other concept within this sensitivity and specificity. Okay, likelihood ratio. There is another term, likelihood ratio. Okay, but within positive predictive value means how much it can predict. Okay, that means positive predictive value. At least try to know the formula. Okay, but if you want to know more, about PPB and NPB, you can ask me anytime, okay? Either in a group or in personally. Okay, positive predictive value, the proportion of patients who test positive will actually have the disease. It's try to confuse with sensitivity and specificity, but it's about proportion. It's about proportion. Okay, I recently taught concept of proportion, rate ratio proportion. Okay, in your juniors, and I think you recall the same concept of rate ratio and proportion. It's a proportion of patients who tested positive who actually have the disease. It's a proportion. Negative predictive value means proportion of the patient who test negative who are actually free of the disease. And proportion, PPB and NPB are not fixed characteristic of the test. Actually, there is one difference. Okay, sensitivity and specificity are quite fixed, because these are properties of kit or screening test itself. But positive predictive value and negative predictive value are not fixed. These are population characteristics. Okay, previous one is test characteristic. These are population characteristics. They are not fixed. If you increase the prevalence, it will increase positive predictive value. Okay. So you can see same figure, 2x2 table. Disease COVID positive, COVID-19, test positive, test negative. And what the test shows, all people with positive result after application of our sensitivity test or RDT kit. So we have this result in our hand, and this result, we don't know how many true or false negative. Okay, so if we apply the same concept regarding PPB and NPB, so what will happen? You can see. So out of total positive, okay, results given by that particular RDT kit, we have actually 82 positive cases. So true positive divided by total positive through this test. Okay, so if you increase the prevalence, so let me brief you in my next slide. This is 80 by 180. This is just calculation. Okay, 80 by 180 means positive predictive value. I'm not sure you are able to understand all the concept. Sorry for that, but hopefully if you interact with me again and again, I'll try my best to clarify this concept. But in your level, try to know sensitivity and specificity. But you have good understanding of sensitivity, specificity, positive predictive value, negative predictive value, likelihood ratio, LR, likelihood ratio positive, likelihood ratio negative, and ROC curve. Okay, these are very important. It will really help you, okay, to understand medicine in terms of population health. Okay. So you can see 80 by 180 means it's a positive predictive value, 44%. So the positive predictive value for that current scenario is only 44%, and the negative predictive value is 19%. Okay. So to rule out, it's good. Okay, to rule out any disease, it's good. because it has 98% positive to rule out any disease. The clinical significance, if you try to rule out, so this test would be great because it has 98% negative predictive value and only 44% positive predictive value in terms of rule out any disease or disorders. Let me go to next. Okay, and the PPV primarily depends upon prevalence of the disease in the population test and test itself, sensitivity and specificity. So sensitivity and specificity are quite fixed, but positive predictive value and negative predictive value depends upon. So this is somehow complicated MCQ question. Okay, those who attended class, then they can answer. Otherwise, it's very difficult. Okay, it's not in a fast track 2 and in a part 2. Okay, if you try to how PPV depends on, or what are the factors which can change PPV, positive predictive value, means the sensitivity and the specificity of test and the prevalence of the disease. In general, it depends more on the specificity and less on sensitivity of the test if the disease prevalence is low. Okay, you can see now the final calculation of prevalence. So if we have prevalence 50%, okay, you can see on your screen, sensitivity 50%, specificity 50%, positive predictive value again from 50% same. Okay. So in this next slide, if you decrease PPV, sorry, prevalence, if you decrease prevalence, then PPV also changed. It also decreased, okay, 20%. So if you increase sensitivity, what happens? It increases PPV, okay, positive predictive value. So these slides are available in your Google Classroom, so you can do it again and again, even in my video recording too. Okay. Okay, now we can see prevalence 20%, sensitivity 50%, specificity 90%, then positive predictive value 56%. It restored its sensitivity but changed the specificity. So it's more important than changing sensitivity. So specificity has more impact on positive predictive value than sensitivity. This is inference from these slides. Okay? And you need to recall these things in your MCQ test. We need to acknowledge, we need to cite experts or writers or research article authors for this good presentation or discussion. So I'll try my best to acknowledge Leon Goddy's epidemiology book. So this is one of the good book. Another one is your own art book and lectures on epidemiology by John Hopkins Bloomberg School of Public Health. So you can easily download John Hopkins Bloomberg School of Public Health and other websites from US universities and Australian universities. So especially Australian and universities and US universities, you can find a good presentation or concepts. So for further reading, if you want to master in clinical epidemiology. So as usual, today I'll definitely post some questions or reflections in your Google Classroom. Please attend, and it has significant value. Okay, I hope at least you understood 25% of today's lecture. And if so, then I'm more than happy. Regarding the rest, you need to have constant mentorship. For that, you need to contact with me or other concerned person again and again, individually or in a group, so that I'll try my best to transfer my knowledge or our knowledge for future doctors, so that you can do good for humanity. That's all. That is the ultimate goal of medicine: improve the humanity and work betterment for our society, populations. I think I need to stop here.